Hello, my name is Rob Martinez. I'm the Vice President of Business Development and Scientific Affairs with BioGX. Welcome to our webinar series that focuses on rapid diagnostics of emerging diseases. It's a pleasure to welcome back today's speakers, Dr. Margie Morgan and Dr. Deisy Contreras from Cedars-Sinai Medical Center. Dr. Morgan is the Director of Clinical Microbiology and Professor at Cedars-Sinai Medical Center. She earned her doctorate in microbiology and immunology from the University of Oklahoma and completed a postdoctoral fellowship in clinical microbiology at the Mayo Clinic. Dr. Morgan is board certified through the American Board of Medical Microbiology. Today, Dr. Morgan has over 100 abstracts and publications, and she's recognized as a thought leader in the field of clinical microbiology. Dr. Contreras is the Assistant Director of the Clinical Microbiology Laboratory at Cedars-Sinai. She earned her doctorate in biomedical science and translational medicine from Cedars-Sinai and completed a postdoctoral fellowship in clinical microbiology at UCLA. She is board certified by the American Board of Medical Microbiology. And since joining Cedars-Sinai in 2020, Dr. Contreras has been instrumental in implementing numerous molecular diagnostics assays for clinical virology and the special pathogens team. Her passion lies in leveraging next-generation sequencing technologies to identify emerging pathogens and advance the field of infectious disease diagnostics. Today, Drs. Morgan and Contreras' presentation will focus on diagnostics of Pneumocystis pneumonia respiratory infections in their presentation entitled Development of a PCR Diagnostic Test for the Detection of Pneumocystis jirovecii. Dr. Morgan, I'll hand over the presentation to you.
Thank you very much, and thank you for that wonderful introduction. So we'll start with the next slide. I think we'll get us started all on the same page with talking about Pneumocystis, the organism. I've dealt with this organism for a very long time in microbiology, and it's gone through multiple changes since we first started seeing this organism when HIV became such a problem. But originally, it was thought to be a protozoan infecting both rats and humans and was named Pneumocystis carinii. DNA analysis in 1988, based on RNA and gene sequence studies, revealed that it was more closely related to fungi. The name Pneumocystis jirovecii was chosen to honor the parasitologist Otto Jirovec, who originally recognized that there was not just both a rat and a human form, and he had recognized initially the human form and gave it, and so the name for the human form of Pneumocystis was named in his honor. It's very interesting that this Pneumocystis is kind of what I would say halfway between a parasite and a fungi, but it is now classified as a fungi but the cell wall contains cholesterol rather than ergosterol, which differs it from fungi. It makes for a less rigid type cell wall. So it's not a typical fungi. It's certainly not culturable. And detection has historically relied upon microscopic identification using different types of staining techniques. Next slide. Potentially lethal opportunistic infection affected immunocompromised patients. And over time, the primary risks for Pneumocystis infection included human immunodeficiency virus. It was an extremely rare infection prior to the AIDS epidemic in the late 1980s. And I have to admit, this is when I was introduced to this pathogen, and it became a very, very common occurrence in HIV. Incidence has decreased in recent years, but remains a major complication of HIV. It affects these patients due to the low CD4 cell counts, and those that are not receiving medical care, they're the most at risk. But you know what? It doesn't just affect HIV. We have now started seeing Pneumocystis infection with hematological malignancies, solid tumors, solid organ transplants, autoimmune conditions, and immunosuppressive therapies. We also saw it during COVID in damaged lungs due to COVID infection. Next slide, please. How does the transmission work for Pneumocystis? It was originally thought to be by droplet. But increasing evidence has been shown for airborne route of transmission from person to person. So droplet precautions means that infections are transmittable through air droplets by coughing, sneezing, talking, and close contact. But airborne makes it far more problematic. Particles can remain in the air, and precautions can be required whenever entering a patient's room or environment. Most of us have been infected with this organism because of its passage throughout the environment by the time we're around 4 years of age. But colonization can come and go over time in the normal host. And there's increasing evidence of transmission from person to person and possibly through exposure to environmental sources. Colonization in less than 20% of humans may be a risk for infection later in years or if you become immunosuppressed, and play also a role in transmission. Next slide. An HIV-infected patient will likely have a very indolent disease and subtle onset of symptoms such as non-productive and dry cough, low-grade fever, and progressive shortness of breath. And this whole process can last over several weeks. Those not infected with HIV may have a very different type of infection. It may be a more abrupt onset of symptoms and accompanying respiratory distress or failure. Both patient groups can present with hypoxemia and respiratory distress at the time of presentation. I guess the bottom line gets down to there's really no classic exam findings that point directly at a pneumocystis infection, but many findings indicate an ongoing respiratory illness such as pneumonia. So this even speaks more toward having a good test to be able to use to diagnose these types of infections in either an HIV or not HIV infected patient. Next slide, please. This would be an example of an HIV infected individual, 65-year-old man with shortness of breath, fever, and dry cough. He's ill appearing with shortness of breath on exertion, has chest pain. Symptoms have progressed slowly over the last month. He has a temperature, his blood pressure is a bit elevated, and he needs oxygen because his O2 saturation is only 88% on room air. He has scattered fine crackles when you examine his chest with a stethoscope, and they think he's suspicious for pneumocystis. They put him on therapy, trimethoprim sulfa, while pending pneumocystis confirmation by laboratory testing. And if you look on the right-hand side, you can see one of the classic hallmark findings of PCP on CT scans is diffuse ground glass opacity, which reflects accumulation of intra-alveolar fibrin, debris, and organisms. So this is the way the case would present in HIV. Next slide, please. But in the not infected with HIV, let's look at this 64-year-old female with fever and respiratory failure. She's had a 6-week course of dexamethasone for an inflammatory issue, but she's coming in acutely ill with an elevated temperature. She has a normal white blood cell count and a procalcitonin in a normal range, making a bacterial infection less likely. She's in a respiratory failure with an O2 sat of around 85%, chest pain without signs of coronary heart disease or pulmonary arterial embolism, so most likely she has some kind of a pneumonia. The chest x-ray showed bilateral disseminated infiltrates. She's placed on a ventilator to assist with breathing. When we looked at this case, there's many possibilities for infectious process, and diagnostic testing is underway because there is really no clear sign or symptoms of what this patient might have. And if you look at this chest x-ray, you can see there's diffuse bilateral perihilar interstitial infiltrates. And these changes are consistent with, but not in any way diagnostic for pneumocystis. Next slide, please. So how can you start trying to diagnose pneumocystis? Well, there are some serum tests that have been used over the years for both the HIV-infected and HIV non-infected population. The first one is the beta-D-glucan. It's a component of the cell walls of many fungi, including that of pneumocystis. If you have a very high value, greater than 500 picograms per mil, it is supportive, but certainly not conclusive for a diagnosis of pneumocystis. You could also look at elevated lactate dehydrogenase. These levels should move you to further investigate the diagnosis of pneumocystis pneumonia, but also other things can cause elevated LDHs as well. And so it makes for a rather non-specific test. Both the beta-D-glucan and the LDH levels can provide helpful diagnostic support in settings where invasive testing methods for PCP is either unavailable or too expensive to be performed. But they are certainly not in any way conclusive tests for pneumocystis pneumonia. We need something more. Next slide, please. So what can we do as far as choosing the optimal respiratory specimen to provide good testing for pneumocystis? For a long time, we have relied upon sputum induction. It's not as benign as procedure as you might think. It involves a lot of inhalation of hypertonic saline, and it can be somewhat problematic for the patient. But it is non-invasive method. The patient must be stable, but as I said, even at that, it can present some problems. Less expensive and a time-saving alternative to bronchoscopy, however, which has become the gold standard for PCP diagnosis. Unfortunately, the quality of inductions can vary, so you're not quite sure the quality of the specimen that you might receive in the laboratory. As I said, bronchoalveolar lavage over time has become the specimen of choice, particularly when induction is not possible or has become a non-diagnostic specimen. Usually a bronch is well tolerated, but it is an invasive procedure, not without problems. And of course, it does have some costs associated with it. If you have an intubated patient, endotracheal specimen can be used to look for pneumocystis as well. Next slide. How about diagnosing using the GMS stain, mostly performed in a cytology laboratory? The GMS stain highlights the cyst walls of the pneumocystis and is the stain of choice for respiratory specimens. You can see over on the right-hand side, the organism appears as round structures around 5 to 6 microns in diameter with a thickened cyst wall and a visible central nucleus. Cysts can also appear crescent-shaped or like deflated ball in appearance. In the early HIV/AIDS era, studies reported GMS stain sensitivity in respiratory specimens to be 90 to 95%. But these patients usually had large number of organisms, and they were very easy to diagnose using such stains. However, the lower burden of P. jirovecii organisms in HIV not infected immunocompromised patients make GMS stained sputa and BAL a little bit less sensitive for the detection of pneumocystis infection. Next slide, please. How about the staining methods that we've used in microbiology over the years? The primary one has been direct fluorescent antibody, or DFA staining. This stain, of course, was a monoclonal antibody-based assay labeled with fluorescein isothiocyanate, direct stain, one-step process with results in less than an hour. We lived and died by this stain in microbiology for multiple years, but recently it was of great difficulty obtaining quality control material, making it difficult to continue with this test method. You could do multiple types of specimens, bronchial washing, BAL, or induced sputa. It would detect the life cycle forms of both cysts and trophozoites of the pneumocystis. Those are the good things. It did have specificity, but it lacked sensitivity, especially in the HIV not infected population. I think we were spoiled over time with the HIV population producing such large numbers of organisms, thinking this stain was the end all and that it was very, very sensitive. But we have found over recent times that it does lack sensitivity in the HIV not infected population. There can also be subjective reading of the DFA slide that could lead some errors in interpretation. Negative stain results certainly did not exclude the possibility of infection. Next slide, please. So what do we need? Well, we're looking for a better test. We need something suitable and sensitive for both HIV and non-HIV infected population. We need a test methodology that's suitable for multiple types of respiratory tract specimens. We need less subjective test interpretation than the DFA slide performance provides us. And we need an easy to perform with reasonable time to results. And with that, I send you over to Dr. Contreras, who can further discuss the development of our new test. Thank you.
Thank you, Dr. Morgan. I'm going to switch gears a little bit and focus on alternative diagnostic approaches for pneumocystis pneumonia. Traditionally, as Dr. Morgan has mentioned, diagnosis of PJP has been traditionally done by clinical symptoms with confirmation via visualization of the stain organism, whether it be by immunofluorescent or non-immunofluorescent stains, as Dr. Morgan had just reviewed. Notably, these traditional methods are known to be less sensitive due to varying factors such as the quality and the specimen type, as well as the skill level of the clinical lab scientist reviewing the slides. These prevalent cyst stains may also be underestimating active infection, which is mainly characterized by the predominance of the trophozoite life form of the disease. Recent advancement in diagnostic platforms have introduced alternative methods for the diagnosis of PJP pneumonia as we see them. As you can see, this slide is just an illustration and overview of what methods are available for the detection of pneumocystis pneumonia. Dr. Morgan had wonderfully reviewed some of these, such as the alternative diagnostic tool as is utilized in an ELISA technique to detect IgM, IgG antibodies against pneumocystis. There are various immunogenic antigens that highlight potential both of natural and synthetic origin, as shown on the diagram. But one of the biggest limitations that we've come to learn and continue to experience about from these types of assays is the immune response may be variable depending on the nature of the immunocompromised individual, and ultimately may affect the sensitivity of the assay, making it or rendering it non-specific. Another issue is previous clinical infection or subclinical exposure to pneumocystis may also impact the immune response and lead to potential false positive situations. So they're not specific and not ideal. Secondly, Dr. Morgan did also touch upon biomarker assays that can bind and aid in the diagnosis of pneumocystis. The more classical example, of course, was the beta-D-glucan, which is also a constituent of the pneumocystis cyst life form. But as you know, it is also found in other clinically relevant fungal pathogens as well. The only true advantage to these non-specific assays is that they're really non-invasive in nature. Other biomarkers such as LDH, KL6 have been found elevated in patients with pneumocystis pneumonia relative to those without. But do these raised levels likely reflect true infection, or are they really a representation or reflection of the underlying lung inflammation and injury, but not specific to pneumocystis? And more studies would need to be conducted to really relay that information. Molecular methods of detection, such as RT-PCR or loop-mediated isothermal amplification, seem to be more promising and specific for the diagnosis of pneumocystis. So let's take a closer look at these two methods. So as you can see, RT-PCR and LAMP-mediated platforms are both laboratory developed tests. There isn't a standard FDA approved test in the market as of yet. RT-PCR has been shown to be more sensitive when compared to traditional staining methods. Of course, high sensitivity and specificity is observed in both HIV and non-HIV patient populations. It has increased sensitivity, therefore a false negative is rare, specifically when the right specimen type is used. High specificity means that a positive PCR is suggestive of the presence of pneumocystis pneumonia or pneumocystis DNA. But is it always indicative of infection? We'll take a closer look at that later. When compared to PCR, LAMP-based methods can serve as a great alternative to PCR, but they come with limitations themselves, right? There's been limited studies that do show that the specificity and sensitivity of the assay is very comparable to PCR. But based on our patient population needs, we believe that RT-PCR was the best method moving forward in designing this PJP PCR. So we decided to go ahead and implement the BioGX Pneumocystis open system PCR reagents. This is a multiplex real-time PCR based qualitative detection of DNA from pneumocystis. Target the major surface glycoprotein, also known as MSG, and it also includes an internal sample processing control that controls the analytical portion of the assay from beginning to end. We've used BioGX reagents in the past, and our laboratory has found it very helpful in implementing these tests because we are able to use available equipment available in the laboratory, right? Our personnel, our clinical laboratory scientists are familiar with the actual workflow and procedure, so minimal training is actually required. It gives us a fast turnaround time where we can provide the clinical team with actionable results. We have found them to be good quality tests. They often have high sensitivity and specificity. And then we have the ability to implement and validate the test on different specimen types that make sense within our patient population. It also decreases user hands-on time when compared to the DFA stain preparation procedure due to the RT-PCR procedures being straightforward and more relevant. So clinical samples that we validated on the open testing system include the gold standard sample of bronch lavage fluid for the diagnosis of pneumocystis pneumonia. This is considered to be the highest quality respiratory sample. When performed after a negative induced sputum testing, it has been noted to yield a diagnosis in 51% of cases. And if negative for pneumocystis, it allows for the discontinuation of treatment within a clinical study. Obviously, the critical limitation in obtaining a bronch lavage specimen is that it's an invasive procedure, it's expensive, and it carries a lot of risk to the patient. And a lot of these extreme respiratory distress situations, it may not always be feasible for patients with severe pulmonary disease. Another great alternative specimen type that we validated on the system is sputum, specifically induced sputum. We found literature has shown that it has greater than 95% negative predictive value in a low prevalence situation, making a negative test adequate for ruling out pneumocystis pneumonia by PCR. So here, let me just shift gears a little bit and give you an overview of the procedure from start to finish, from pre-analytical steps to the analytical and then post-analytical, right? So collection of a bronch lavage or a sputum or induced sputum, right, begins with the pre-treatment of this viscous sample type. In our laboratory, we decided to go with a method that is already in use and our CLSs are used to. We are currently using the SputoDigest 50 mucolytic agent. We add that to a 1:1 equal volume. We homogenize well. We incubate at room temperature for 15 minutes, intermittently vortexing and homogenizing the sample, allowing for the agent to work its magic. We centrifuge, we deactivate the mucolytic enzyme by adding PBS to the 50 ml mark. We spin, we decant, and leave approximately 1 ml of working specimen to test. The total inoculation volume required for the test is 200 microliters. And this is where the BD Max portion comes in, where we use the extraction kit provided by BD. We inoculate our sample buffer tubes. We incorporate BioGX's open pneumocystis reagents, including primer probe systems and rehydration buffers as seen on the right-hand side. We run it on our BD Max open testing system with the specified vendor file. And it approximately takes, for a full 24-hour run, it takes approximately 2.5 hours from start to finish. So when conducting a validation on a laboratory developed test, there is a lot of parameters that one needs to establish, right? And one of those parameters includes analytical sensitivity. So we want to know what the limit of detection of our assay is on these two types of matrices, right? Our bronch lavage and our sputum. So for this type of study, we use the pneumocystis template control that is equivalent to 10 to the 5 DNA copies. We serially diluted in simulated bronch lavage and process-induced sputum negative matrix, and we measured its limit of detection, right? We did serial dilutions from higher concentration to lower, and we found that it has really high sensitivity, right? For our bronch lavage, since the majority of our bronch lavages are not processed, it gave us a little bit more of a wiggle room, right? So the lowest concentration level was observed to be at 75 copies, while the sputum, induced sputum, gave us at around 100 copies to be exact, which is pretty good for a pretty good sensitivity for a test within our patient population. Another parameter that we establish is analytical specificity. So we want to make sure that any other organisms that could come across, we want to see if there's correct identification of pneumocystis or if there's any cross-reactivity between any other organisms. And we tested a wide variety of fungal pathogens and critical bacterial pathogens, including some of our mycobacterium isolates, which we can see concurrently with pneumocystis infections. And we found that pneumocystis did not cross over and was specific, decreasing the chances of any false positives, potential false positives. Accuracy, this was a seed and recovery study that was performed on 120 specimens, positive and negative specimens, for both sputum and BAL clinical samples. We took negative matrix associated, we contrived them with pneumocystis template DNA. We approximately had 80 positive samples that span the limit of detection from high, medium, and low. And then we also included 40 negative samples as well. As you can see, the assay demonstrates high sensitivity and specificity, which is in line with current literature. Another parameter that we measured was precision, right? We want to make sure that we're getting the same results, different users over a specified time period. So we did this over a 5-day period in triplicates for both sputum and BAL specimen contrived samples. And as you can see, we did it at 2 different concentrations, 2x LOD and at 4x the LOD, and also included negatives. We did this over a 3-user period, over a 5-day period to measure interprecision studies. And as you can see, we found that the assay had excellent reproducibility with both intra and interprecision to be 100%, making the assay very reliable. Like I said before, this was also repeated for the BAL matrix samples, and similar findings were observed. We also want to know specimen stability, right? We wanted to test for both processed sputum and bronch lavage specimens contrived with pneumocystis template control at 2 times the limit of detection for positive samples. And negative specimens as well were also included. We tested at day 3, day 7, and day 14 at a storage temperature of 4 degrees Celsius. Typically, we found good. This is a qualitative result chart that actually allows you to see that even at day 14, we got 90% recovery of our specimens. There's a total of 30 specimens with at day 7, which is what we said our specimen stability at, was 100% recovery from day of collection, which is great. So along with these establishments of these different parameters, such as analytical sensitivity, analytical specificity, we also did a mini clinical evaluation. So one of the major reasons why we wanted to switch from a DFA to a molecular platform was not just because of its increased sensitivity, but also there was a reagent shortage. And by a reagent shortage, meaning that there wasn't any positive control that we can use to run the test with, at least within our institution. So post-COVID clinical setting painted a different picture where we weren't getting our positivity trend was decreasing, right? So we didn't have enough of that control to actually include or continue to test. So this also prompted us to look for alternative ways, such as this assay. So for the clinical evaluation, one wants to include positive and negative samples, but due to the shortage of positive samples, we were only able to include negative clinical specimens in this study. So I took a total of 50 previously tested BALs and induced sputums, mainly induced sputums because that's what microbiology focused our testing on. And I ran them through the developed PCR, the Pneumocystis PCR, and we found that 3 out of the 50 specimens actually was positive on the PCR, but was reported negative by the DFA. So in clinical sample 20, as you can see, not detected by DFA, resulted by the laboratory as not detected. This case is actually a 73-year-old female with breast cancer, right? She has a history of breast cancer. She's immunosuppressed. She comes and presents to the ED with shortness of breath, cough, a very clear respiratory distress presentation. Based on the DFA, we resulted as not detected. If we had the PCR back then, it painted a little bit different picture. It actually would have been resulted as detected. Second example would be clinical sample 32. This is actually a 54-year-old male who's HIV positive, who also presents to the clinic with respiratory distress, respiratory symptoms, shortness of breath, also DFA negative, but with the PCR, we were able to get a detected result. Third case, where we actually found a discrepancy between the DFA and the PCR, was with a 48-year-old HIV positive male who had respiratory distress, but was not as severely at presentation as the other two, right? So these findings already tells us, yes, we've proven that the PCR that we've developed and validated is sensitive enough to pick up these subtle cases where we would have missed by DFA. But in 2 out of 3 cases, they were able to actually ignore the DFA, right? They didn't pay attention to the DFA result, negative result. But the clinical team felt strongly enough that there was a pneumocystis component to this clinical presentation that they decided to treat the first 2 patients with pneumocystis specific treatment and prophylaxis. So the third case, there was no pneumocystis treatment associated with this case. So what is the difference? Now I'm going to point to you what the CT value is, right? So the CT value, as you can see, gives us a really high CT value, right, of ranging from 36.2 all the way to 38. The 2 above, the first 2 cases, they were able to treat. The clinical team ignored the DFA negative results. And they knew that they had to treat these two patients with some type of pneumocystis specific treatment in clinical management. This lets us so these findings, even though we have a high sensitive PCR, it lets us and prompted us to ask more difficult questions, more other questions, and led us to, to develop challenges on how to address these types of situations. So some of these challenges that we learned about while developing these tests is, what do we do with these interpretation of low fungal burdens, right? Quote unquote colonization. So detection of the low fungal burdens, there isn't any clinical significance, especially is there a potential benefit in these non-HIV immunocrossed population where low fungal burdens may be significant in the clinical management of these types of patients. There isn't any standard established cutoff values for cycle thresholds that distinguish pneumocystis acute infection versus colonization, right? So we had to really think about how we are able to result these types of molecular results so we don't confuse the clinician, right? So that's another challenge that we have to face, is the clinician's understanding and utilization of the test. So what we did in the laboratory to combat some of these challenges, some of the resolutions was that for any positive PCR result that had a greater CT value of 35, Dr. Morgan and myself will get involved and do some deep diving chart review before releasing the results. This may include consultation with the clinical team in terms of really deciding whether this case is acute infection versus colonization. We also did some extensive education with the clinical team, right, on the new assay and its implications and its high sensitivity and specificity and what it really means to interpret some of these results and facilitate early diagnosis. But overall, this was a positive experience both from the laboratory and the clinical team in meeting a diagnostic gap and actually filling that gap with a better test that takes away the subjectivity and some of the sensitivity issues that come along with it. So overall, testing of respiratory specimens such as sputum or BAL were found to have high sensitivity, specificity, and reproducibility for the rapid detection of pneumocystis. The pneumocystis pneumonia RT-PCR has provided rapid results with minimal hands-on time within approximately 2 to 2.5 hours of setup, which is considerably more rapid than the standard DFA method, which can be more laborious and include a lot of hands-on procedures and difficulty, obviously, when it comes to the post-analytical analysis and interpretation, where limitation and experience of the clinical laboratory scientist come into play. Overall, the development of this pneumocystis rapid PCR utilizing the BioGX reagents has had a great impact and has been a very helpful addition to our microbiological diagnostic platforms. And that is it for me.
Thank you very much, Daisy. That was a great presentation, highlighting your implementation of the pneumocystis molecular test on the BD Max. We have a few questions, and start off here. So you made the transition from DFA to molecular diagnostics. How did that transition occur in the lab?
I can start and Daisy can second. Of course, the transition in the laboratory, I'll let Daisy address because she did all of our competency training in the laboratory. We also presented to our stewardship committee, our infection control committee, and individual ID physicians that I communicate with about this new test. So they were they were very well aware of what we were developing. And when it went live, they were very aware of who to contact if they needed questions answered concerning the implementation of this test. And Daisy, would you like to talk how we went about it in the laboratory? I'll also make one other comment. Of course, we always are obligated to do a laboratory service bulletin, which is attached to our computer network so anyone can access new information about our testing. And Daisy, why don't you discuss how we implemented it within the laboratory?
Yeah, definitely. So the implementation within the laboratory was a smooth transition. Like I mentioned before, prior in the presentation, when bringing on a new test, you want to be able to use your existing equipment, right, with existing workflows. And we were lucky enough to develop this test on the BD Max, which a lot of our clinical laboratory scientists are very well familiar with the workflow and how the procedure is. So minimal training took place. They were comfortable with the actual procedure itself from start to finish. The analysis of results, our resulting algorithm was clear to them. So it was a very smooth transition, and it was welcomed and appreciated by the clinical laboratory scientists because it also reduced hands-on time that they did and took part in performing that DFA stain.
Excellent, thank you. So in your presentation, you showed that that there's natural colonization that occurs in individuals that aren't presenting respiratory distress. So I think one of the challenges is kind of discerning with a molecular test whether or not there's colonization versus infection. Is that really something that you have to consult with a physician to really confirm colonization versus infection?
I'll start with that and then let Daisy continue. It is an important point, as I discussed, as well as did Daisy, that colonization is certainly a possibility in the detection of a PCR result. But as Daisy suggested, we have this algorithm that we have created to discuss with physicians, if necessary, about high CT values and the possibility of whether it is colonization or true infection. After all, in the end, we do have to leave it to the physician to make that determination based on other factors, not just our PCR assay, if it could possibly be colonization. Daisy, do you want to continue on that?
Yeah, just to really drive the point home, it's with infectious disease diagnostics, it's not just solely based on the test. There's a bunch of parameters, including from the clinical side, right? And other clinical tests that come into play together in harmony that actually support the diagnosis. But we also added a disclaimer on our reporting that addresses this issue so that the clinicians from the clinical side are aware, and our physicians are not shy. If they have an issue with what our results are, they'll contact the lab. They'll have a conversation with Dr. Morgan or myself, and we'll explain the situation. We'll walk along with them, look at the clinical picture together, and really decide as a team. So it's been a collaborative effort, and I feel it's been a positive experience overall.
Excellent, thank you. Another question is concerning when you have both HIV and non-HIV patients that present respiratory distress, you get to a point where the infection can be fungal, being pneumocystis, bacterial, being a potential mycobacterium, or some of the atypical pneumonia pathogens like mycoplasma, chlamydophila. Can you comment on how you would kind of hone in on which test to use in those scenarios?
Well, I think that would be in talking with the clinicians. It wouldn't be our decision alone, certainly. I am not an expert in clinical findings or clinical symptoms, shall I say. So it would have to be in discussion with the physician if they are confused or need assistance with what tests would be best to use to diagnose a complicated patient. It might involve the use of many, but we can certainly talk them through what is available and perhaps provide a direction. But this would certainly have to be in combination in discussions with our clinicians. Daisy, would you like to add to that?
I totally agree with you and what you said. It's a collaborative effort. And like I said, at least we have this diagnostic platform to offer them to rule in or rule out pneumocystis. Other laboratories might not have the ability to do that. So it just gives us an upper hand. And I think, like Dr. Morgan said, some of our physicians might get a little, you know, they're lucky to have this option, and we're here to consult with them and help them along to make the right decision.
And you are right. Sometimes we have to. They may not be even fully aware of the breadth of all the tests that we do have, and the meaning of some of them and such. So I do think that the laboratory plays a very, very important role in the selection and the interpretation of these assays. And I think it's a role that we very much like to participate in.
Excellent. Thank you very much. Actually, I think we'll end it there with the questions, but I asked the audience if there's any additional questions that come up. We ask them to submit it to info@biogx.com. And Drs. Morgan and Contreras, thank you again for your time and sharing your insights on pneumocystis diagnostics. And that will conclude our webinar for today. Thank you.